I'm Dr. Denise Korniewicz, and we'll be speaking about surgical site infection and double gloving. The objectives of today's lecture are fivefold. First, to define surgical site infection. Second, discuss surgical wound classifications. Third, recommend prevention strategies for surgical site infections. 4, to discuss a little bit about the use of double gloves as prevention in surgical site infections. And last, to talk about infection control and surveillance. Surgical site infection is a real problem in the United States. 325,000 surgical site infections occur annually. 1/3 of those become nosocomial infections, accounting for 14 to 16% in hospitalized patients. This costs the United States a lot of money, over $1 billion annually. Surgical site infections remain a problem because of the cause of morbidity and mortality among hospitalized patients. Surgical site infections are the third most frequent cause of nosocomial infections in hospitalized patients. 38% of surgical patients become infected by hands of healthcare workers and or from issues that happen during the surgical procedure itself. A common complication of surgery usually includes intra-abdominal or extra-abdominal operations, meaning 2 to 5% of clean extra-abdominal operations can become a surgical site infection. And up to 20% of surgical site infections occur intra-abdominally from procedures that are deeper into the abdominal wound. This is one slide that shows some of the complications associated with surgical site infection that has lots of complications because of the wound healing process. There's different definitions of surgical site infection, and most commonly we want to standardize exactly what those definitions are. Based on the Centers for Disease Control, certain surgical site infections have been classified into major areas. The first, meaning subcutaneous or skin, is one surgical site classification. The second is deep incisional classification, and the last is organ space. When surgical wounds go from the skin all the way proceeding down to the organ space, it gives us an idea of how difficult the wound may become to be healed, and secondly, how long it may take to use antibiotics and to heal from the inside out. Surgical site infections are classified, and most individuals use them as superficial, deep incisional, or organ space. And this is a table that basically demonstrates and shows that the CDC classification for surgical site infection. Why do they occur, and how come they occur is another issue. There's many issues associated with surgical site, beginning from the time that individuals are pre-op for their care. The first, of course, is the individual themselves undergoing the surgical procedure. One has to have preoperative antiseptic showering or to clean their skin prior to any type of a surgery occurring. Second, if there's pre-op hair removal. It's not recommended today to really shave areas other than if they're very specified by the surgeon, because shaving causes nicks in the skin which can lead to actually a surgical site infection. However, some individuals have preoperative hair removal by actually removing, by using tweezers to remove the hair. There's also preoperative hand scrubs that are completed, and that's very important because of the skin to glove to wound contamination that can occur. And last, the patient's skin has to be prepared just prior to the operative procedure in the operating room. This is one slide that basically shows, this is from the University of Maryland, that demonstrates instructions to patients. So patients should get instructions associated with preoperative cleaning prior to the surgical case. Intraoperatively, there are other issues associated with surgical wound infections. One is the operating room. The operating room environment needs to be not only clean, but a certain temperature to keep the sterile field and the environment cool so that wound infection does not happen. Secondly, there are things associated with sterilization. And sterilization not only includes what the garb or the clothing of the healthcare workers, but it also includes the sterile field and the environment in which the patient is undergoing the surgery. Instrumentation also have to be sterile, and that all those, the way that the environment is set up decreases the rate of contamination or the rate of surgical wounds for the patient. Then there's the surgical personnel and the principles and the guidelines that surgical personnel need to be aware of in order to maintain a clean and sterile environment. And last, there's antimicrobial prophylaxis or antibiotic use prior to the surgical procedure. Ways to decrease any problem associated with sterilization of, say, one's tray or in the environment are putting reminders on for surgical staff so that any type of an indicator is clear on the patient's tray so that we know that it's a sterile tray versus a non-sterile tray. Other things that can make the surgical site infections occur is what the patient brings to the operating room themselves. For example, if patients have a history of diabetes or nicotine use, steroid use, or if they're malnourished or don't have the proper nutrition, can all increase the rate of surgical site infection for that individual. Other types of characteristics can mean a longer patient stay if the patient comes with their own baggage or their suitcase full of issues if they're not a very healthy individual. The CDC has a risk stratification method of looking at wounds and looking at surgical sites. And this risk stratification, which is known as the surgical site risk stratification survey or surveillance, it really looks at both intrinsic and extrinsic factors that classify surgical wounds or wound classification. And some of the variables that they look at include wound classification, length of surgical procedure, and also the way that the American Association of Anesthesiologists rate wounds is also a patient care risk indicator or classification system. There are several ways to classify a surgical wound, starting from class 1 to class 4. And each way that one looks at a surgical wound gives a rate of expected infection as a result of that type of a surgical operative procedure. Class 1 are known as clean wounds or clean procedures. And this basically is an uninfected operative wound where there's little inflammation and there's no inflammation in the respiratory, genital, or urinary tract. And these clean wounds are primary closed wounds, and they are not penetrating with any type of trauma. A patient undergoing a clean wound procedure has an expected infection rate of 1 to 2%. So it's the least type of an infection rate risk for a clean wound. The second is the class 2, or the clean contaminated wound infection rate. This is an operative wound in which the respiratory tract, genital or urinary tract are entered under controlled conditions without usual contamination. Specifically, operations such as in the biliary tract, the appendix, the vagina, or the oropharynx are part of those in this particular category. Expected infection rates in clean contaminated class 2 wounds ranges from 2 to 4%. The class 3 contaminated wounds is a more difficult wound to heal and has a higher rate for surgical site infection. These wounds are fresh, accidental wounds. They usually occur because of major breaks in the sterile field. In other words, open cardiac massage is one example, or a gross spillage of the GI contents when performing the surgical process. These can be non-purulent in drainage, and they're usually included in this category, but the rate is higher in terms of a surgical site infection, ranging from 7 to 10%. The last wound classification, which is the most difficult to heal, is class 4, which is known as dirty or infected wound. These are traumatic wounds that can be old, they can have devitalized tissue, and they usually have some type of perforation associated with the viscera that can cause organisms into the postoperative field and can cause a surgical site infection very rapidly. These are very traumatic types of wounds. Their rate of infection is usually 40%. So dirty infected wounds are the worst of the 4 wounds that can cause surgical site infection. Now, these Centers for Disease Control has developed a surveillance program known as the National Nosocomial Infection Surveillance Risk Index. And this risk index looks at 3 major factors to classify a wound and to classify a surgical site infection. First, the factor of the wound class, is it 1 to 4? The procedure and how long the procedure lasted. So usually when one looks at procedures, that the higher the number of points, the longer the duration. The ASA class, which is from the Anesthesia Surgical Society, looks at the length of time and the rate of how long one has had a risk to an infection. So the higher the number, of course, the higher the risk for a surgical infection. The American Society of Anesthesiology has the ASA score, and this slide depicts what are the classifications, their definitions, and then the patient characteristics associated with those definitions. And the important concept here is that the higher the classification, the more at risk the patient, with general characteristics associated with underlying systemic disease processes with the patient. If one looks at a basic surgical site infection risk index and one has a high ASA score, one has to look at the duration of the surgery and then the wound class, and note that if it's a longer surgical procedure, such as an example being a cardiac bypass surgery, that these types of surgeries lasting 5 hours or greater have a higher rate of infection because of the length of the surgery and also their wound class. Though they may be clean at the outset, they may become contaminated, meaning during the surgical procedure, which can cause a surgical site infection. Other issues are, of course, in surgical site infection are the postoperative issues, meaning how is the incision being cared for and how is the patient being cared for when they return, when they leave the unit or they return to home. Now, how can we prevent surgical site infections? What do we know? What do we already know in the literature, and what do we know in terms of making sure that the incidence of SSIs do not go up? The first, of course, is good aseptic technique, and that's during the